Okay, welcome to the continuing saga of COVID here in Oakmont. We have as a guest today Leah Gehri, who is Director of Nursing at the Memorial Hospital. And today's purpose is to try to understand more about where the COVID thing is today, treatments, and then we may talk a little bit about where treatments are headed. Of course, you pick up the newspaper every day and you have some information on that. So with that in mind, Sue Dibble, would you introduce Leah to us?
Sure. Leah grew up in Washington State, in a suburb of Seattle, and she grew up water and snow skiing, enjoying outdoor activities that Washington has to offer. She joined the military in the 80s and served 4 years as a Marine. Thank you. She received her Bachelor's of Science in Nursing from Pacific Lutheran University in Parkland, Washington. She got a Master's in Nursing and a Master's in Health Administration, both from the University of Washington. She spent lots of years as a bedside nurse, as many of us have done, all in critical care and emergency department. She's married, has 4 kids, 5 grandchildren, and 1 very spoiled dog. She's also not just the Director of Nursing. She's basically in charge of all of nursing administration and of everything that happens in the ER. So, you know, she has physicians reporting to her. She has techs reporting. She has the whole works reporting to her, basically. And she's in a really good position to tell us a little bit about what's going on at the hospital. And she does not mind questions at the end of what's been going on in Press Democrat, but we really try to keep this more to COVID rather than politics. That would be great. Anyway, so without further ado, Leah, it's yours.
Hi, thank you for inviting me. I'm going to do my best to walk people through what we have learned about COVID. So as some level setting in terms of where we are, you know, as of January of 20, no one knew anything about coronavirus. And by March of this year, it became a very scary thing as the whole country was gearing for a huge insurge of patients, and we did not know very much. But what we were seeing from, you know, Asia, that the mortality rate was high, and it turned out it seemed to be very contagious. So since that time, I think we've learned a lot. And I think if I have one plug, like the number one thing that people can do to protect oneself is to, you know, wear a mask because you're covering your cough. That's the whole purpose of a mask. Eye shields, right, are helpful, because what we've learned over time is that, you know, the virus can, if it gets into people's eyes, that's a way to be infected. And then washing hands. So a little bit about that. I know that there's a whole bunch of things, depending on what you read in the media, about masking and people's rights and that sort of thing. And I think that the masking thing, what I've seen is that it actually works. And all of us are learning every day by what happens, because there's nothing like this thus far. There's been no viruses and no pandemics, no global pandemics in anybody's lifetimes thus far that they can draw upon from actual experience to know what to do about this. But for example, you know, since March of 2020, the emergency department has seen literally hundreds of COVID patients. And we've also ruled out hundreds, if not thousands, of COVID patients. We see almost 5,000 patients a month in the emergency department. And so the majority of COVID patients in our community have managed to somehow work their way through our system. And by good masking, good shielding, universal masking for all patients and all, we don't have very many visitors, but the few that come in, and all staff, we have had 0 conversions in the emergency department. So that is the absolute most important thing. Now, sometimes people will say, you know, you're not wearing a mask. Your mask, or I'm wearing my mask to protect me. My mask does not protect me. And so the important thing to remember is that my mask protects you. And so your mask protects me. And the idea is this. Is this familiar territory for you all, or is this new territory kind of?
Well, it's familiar territory, but it's always worth re-saying.
Okay. So the idea is this, right? If a sneeze, the projectile of a sneeze is about 6 feet. And so that's where the 6 feet mandate comes from. And so if you stand about 6 feet away from someone, and someone were to cough or sneeze, it would have to be a pretty exceptional cough or sneeze to go beyond 6 feet and so that you could breathe it in. So that's why that. And by simply wearing a mask, you're now, if you cough or sneeze, it's not going to go anywhere. If you think about surgeons in the operating room, when they wear all that stuff, that mask is not protecting them from the patient. They're wearing all of that to protect the patient from an inadvertent cough or sneeze, or, you know, any little droplets as they're talking to be, you know, dripping on the patient and infecting a patient in the operating room. So it works very well. And for standard day-to-day stuff, you don't need an N95. So we're not using N95s here unless we're in certain situations where we're likely to create an aerosol. So there have been well, early on, a lot of questions and controversy about whether the coronavirus was airborne or was it droplet. And so it's always helpful for me to think about, to anchor what I know to other things. So there are only a few real airborne diseases, measles being one of them. And so if you think back to a couple years ago at Disneyland, there was a big measles outbreak. And what happened is somebody with measles went traipsing through Disneyland and coughing and probably whatever, sneezing and talking. And as they talked and sneezed and coughed, these little aerosol particles just lived in the air for 8 hours. Very light, very small, just floating around. And as people walked through this invisible cloud 8 hours later, they would breathe in these little tiny itty bitty aerosolized particles, can't see them, invisible, and then they would become exposed to measles. As opposed to a droplet that is heavy, and if you sneeze or cough, it might stay in the air for a half a minute, and then it's heavy, so it drops to the ground. Well, in the early days, when we didn't know if it was aerosol and we didn't know if it was droplet, people were very afraid, and there was a lot of demand for N95s. It turns out that the coronavirus, only when you do certain things, so if a person is getting a breathing treatment, getting a breathing tube put down on them, a lot of medical procedures, suctioning, things like that, it will behave as if it's an airborne virus for about a half an hour after the procedure. And then the droplets are heavy enough that they fall to the ground and it's no big deal. So we only use N95s and cappers and those sorts of things in certain situations when the procedure that the patient is getting would cause this. So this is good news. This is good news for the rest of us out in the community, because what it means is that we don't need N95s to be protected. If people just wear universal masking, it's a good thing. The other thing, back in the early day, there was a lot of information that changed quickly that turned out not to be quite accurate, that this virus potentially lived on surfaces up to 72 hours. So that was a problem. So now it's not lingering in the air for, a day or 8 hours, but it falls to the ground because it's heavy, but then it lives on the ground for 3 days, and then you walk through it, and then you traipse it into your house, and then you sit your baby on the ground, or you're on the ground playing with your dog or anything like this, then people were worrying about contracting coronavirus that way. And it turns out is that it doesn't live, it's not nearly as hardy on inanimate surfaces as we thought. So all of this knowledge is good news, because armed with this information, we can save ourselves from, from exposure. Regarding treatment, so viruses, mostly they run their course. So the coronavirus itself, all of us, there are other coronaviruses. In fact, many common colds are coronaviruses. This is the novel coronavirus. So this one is, turns out it's a little special and it's problematic in its behavior. But what we know from other coronaviruses, we do know a lot about other coronaviruses, and all viruses, they typically are not treated by viral medications, with the exception of there have been some antivirals over the years, notably things to keep HIV and AIDS in place, and a few others that are able to be helpful. And influenza, there's Tamiflu. So if you get influenza and you take Tamiflu early on, what it does is it shortens the length of the flu, influenza, and it makes the symptoms, these antivirals, make the symptoms much less. So some of the treatments that are all out there there's like a mad rush trying to get vaccines and different things, and you see all these treatments in the news, and what works. Is it plasma therapy or hydrochloroquine or, different things? What's working? Is it they're digging up old drugs and trying these as last resorts. And so what they're finding is that in some cases, they're having some successful results from some of these things. But what's hard is that there's no way to study this right now, right? Because if you have a disease that is potentially highly fatal in a certain subset of the population, then if you want to do the double-blinded placebo, which is basically one group is randomized to you get the real drug, the second group is randomized to you don't get the medication. No one knows who is getting it, including the researchers. And at the end, they unblind it and do some analysis, and then they compare the two groups. This disease is not, it's so rapidly fatal, and there's so many variables on how it presents for people, anywhere from asymptomatic to, fatal. There's not really a good way to set up a trial without introducing all sorts of bias. So I think that what we're going to start to see is the best case evidence is going to be a lot of case studies on people looking at what works in similar scenarios and should we try it. And then if it works, they're going to write a paper out of it and publish it, and try to increase the body of scientific knowledge like this while we wait and work on getting a vaccine. There's a lot of trials going on with vaccines right now. I was reading, so, living in the Washington area and being a UW grad, really good medical school, really good research institution. And there's some research trials going on in Seattle right now about a vaccine. And the question remains, is this going to be a virus that mutates? And so like influenza, you need a vaccine every year to try to get ahead of whatever this year's mutation is, versus that's something that's very slow to mutate. And so therefore, you just need, a vaccine at every kind of interval with a booster, and then you're good. So that's kind of where, the stuff that I'm reading and the stuff that we're talking about here, that's kind of where that settles all in. Does that all make sense?
Yeah. If you're ready, let me start with a couple of my questions, then I'm going to open it up to the group as a whole. Okay.
Yeah.
If we go back to New York City in April-ish timeframe,
Yeah.
it would look like a complete disaster zone. You had
Yes.
lots of cases. You had people, the whole ventilator thing, where we didn't have enough ventilators, and a high fraction of people dying who were on. Okay. has the world changed since then medically? And if so, how has it changed?
Yeah, I think so. Like, I think that, anytime, anytime you have a large population of patients who are with the same diagnoses, you're getting, the healthcare profession, they're pulling out their full bag of tricks and learning all the time. And so I think probably a lot in ventilator management. One of the things that is happening quite frequently that came out of New York is, when they're letting gravity do its work. So it's called proning, for example. And back when I was an ICU nurse, we didn't prone patients very often. And proning just means you put them on their tummy, you put people on their stomach. And so if you think about every time you've ever visited a loved one in the hospital, they're sitting up in bed and the little head of the bed's raised and they might have a little, pitcher of water with a straw in it. But people are not basically purposely on their stomach. And so by putting them on their stomach, they're not pushing up to get air, but basically, they get gravity, they get the benefit of gravity. And so, patients get proned, and it turns out that it really helps them breathe. The other thing is that early on, there was a controversy. It's like, do we try to do non-invasive ventilation, like something like BiPAP or CPAP, right? Where, if you have sleep apnea, you might be used to a little, positive pressure. Well, something along that line of thinking where you don't intubate the patient, put the breathing tube in right away. And then there was a move to like, no, don't do that. Just move straight to intubation. And then now it's swung back the other way, that it's actually better to just see if the person can turn their lungs around on their own before they need a breathing tube. So these are all things that, really bore out of the rest of the world and the country and what their experiences were. And, with a large population, they are able to see some commonalities in the treatment and some things that do seem to work better.
Okay, so that's stuff that's been passed on to you in the lore, and your team now has some things they can depend on.
Yeah, the thing is the medical community, they're prolific communicators. And so, in all of the medical journals and nursing journals and every conference that you can go to, and there's, conferences all the time and sharing of information, and people have webinars, and just, all of our national nursing and medicine, in every specialty and subspecialty, all of our things are virtual, and there's a lot out there on lessons learned from COVID everywhere.
Okay. Question 2. I may have come down with COVID. I've had some of the symptoms, but I'm not feeling badly. Okay. So I'm taking care of myself at home. When in that process do I suddenly say, I better go see you?
When you get sick, right? So what I would say is, they're respiratory symptoms. And so if you get to the point where you're short of breath and you're ill, you should come to the hospital. Otherwise, if you're thinking of a few symptoms and you might have it, and you may just go get a COVID test, and then continue to self-isolate at home. If you feel lousy and you get the test and you're negative, then you have peace of mind. If you feel lousy and you get the test and you're positive, well, then and so then you would want to make sure that you're not exposing other people. But the thing is, what we don't want, and we did see this on where people did not come to the hospital, and then when they started coming back, they had waited way too long. So if anyone is experiencing, shortness of breath, chest pain, even confusion and dizziness, that sort of thing, because confusion can be a sign of not having enough oxygen going to your brain. So even if you don't subjectively feel short of breath, the lack of oxygen to one's head might cause you to have some mentation problems that could indicate that. And so we would rather get you in, get you treated. And, if you need to be hospitalized, we can put you in a medically supportive environment, support your symptoms, until this thing runs its course, potentially try some of these treatments that we've got in kind of our bag of tricks to get people through their illness. And then, hopefully you recover and then.
Okay. So last of my questions before I turn it to the group. I am feeling that way. I now go down to your emergency room and walk in. Now what happens?
So the first thing we want you to do is we want you to wear a mask when you come into our hospital.
Right.
Any mask that you have, right? Because we're keeping everybody safe, and every single person. When you walk through the emergency room doors, the first thing that's going to happen is you're going to get screened for COVID symptoms. And so, we have a list of questions that we ask every single solitary person. We go ahead and we take your temperature, and then we have you switch out your mask for one of ours. And then we start the process. We'll get you registered. You'll be seen by a triage nurse. They'll get your list of symptoms. They'll take your vital signs, and then they'll make a decision on, depending on what's going on in back, how long you can wait, what they have to move around to, figure out how to get you in. And then we start with there. We have a list of nurse-initiated protocols. So even if you're not straight back with a doctor, if you need an x-ray, if you need some blood work, we'll often start that stuff right up front in the waiting room, so that by the time you get back to see a physician, some of those results are already starting to come back.
Okay. So that's what I'm used to, having occasionally made my way to your emergency room. That's what I'm used to normally.
And then you call me, and then you all call me.
Okay. How does it differ if I may be a COVID patient? Does it differ at all?
Yeah, well, what we try to do is, if you're in the waiting room, we separate the potential COVID symptoms from the non-COVID symptoms. Thus far, we've been pretty successful with not being inundated with so many patients in the waiting room. But we actually have a tent set up that we've had unoccupied but ready to go since March, in case we do get an influx of people and we need to actually further them. And then, the potential diagnosis of COVID in and of itself doesn't necessarily put you highest on the list of priority. It's really around how sick you are. But we do have a heightened awareness of a potential COVID patient. And the more likely they're with COVID, we want to get you in a room so that we can get you in a room, put you and shut the door, and not potentially have any more infection.
Okay.
And spread.
And you've got negative pressure rooms and all that stuff.
We do, but you only need a negative pressure room if you're doing all of that aerosolizing.
Okay. You mean if I'm not putting the excess aerosol in? Okay. All right. I am going to take you off the spotlight and open up to questions from everybody else. As a reminder, what that tends to mean is the best way to let me know you want to talk is either to wave at me, that will work, or to use the chat function. Okay. And Sue, would you keep an eye on the chat function in case you see anybody there? And I see you've got your hand up, so you got to unmute, and you get the next question.
Yes, I actually have two questions. One is, for old people, fever is not one of those things. I mean, my normal temperature is nowhere near 98.6. And so if I have 98.6, I'm sick. I'm assuming the protocols take that into account.
Yeah, so there's not anything official about where in an adult where you would maybe say, oh, this is it's a lower than normal fever, but it's still elevated. But I think we definitely do take it in account, because it is true that as we all get a little older, we don't run quite as hot as perhaps we did when we were younger. And so if you have the other COVID symptoms, because you can also be completely asymptomatic and completely afebrile, no fever, and still have COVID. So, if you had a slight bump in fever in your temperature and above norm, and you had COVID symptoms, then you would be thought to be potentially COVID until proven otherwise.
And my second question is, I understand the National Guard is there.
Yes, they're lovely.
And how many times have you been manned?
All the time. Yeah, they're great. So, what's happening is it was really the combination of COVID and fires, because we've had COVID here. We started out with just a little tiny bit of COVID, and then we this is now September. I want to say July-ish, we really started peaking. And through, through mid-August, we were continuing to peak. We have dropped off a little bit, but then we had all those fires, and the idea of hospitals potentially evacuating with, also COVID, it was just too much. And so we worked through our, the rest of the community, and there was a governor order. And so we were able to get some National Guards people here, and they're great. They're just extra set of hands helping us out, making sure that patients get great care. They're very dedicated. They haven't been home since April. They've been on mission after mission, and they're just delightful to have.
Mona, you had a question.
Yeah, I have a couple of questions. Thank you very much for your presentation.
Thank you.
When the person presents himself at the hospital and you do go through certain tests, what indicators do you use that the person should be admitted?
So there are admission criteria, and really what it is would be the inability to maintain a normal oxygenation level without oxygen, the need for IV fluids or IV medication, if someone had a blood pressure that was unstable, those sorts of things that if we send you home, this is your vital signs or your status is abnormal enough that you really need to be monitored more closely. So not every COVID patient gets admitted. This is true. The thing is, we do pay attention to comorbidities.
So when do you feel that each person should be admitted? What's the point that between you can send the patient home or should be admitted?
Yeah, so it's going to be completely dependent on how each person presents. So let's say, your oxygen levels were abnormal, they were low. That would be a criteria to admit you, because we cannot send someone home who can't have adequate oxygen levels.
How low?
Without without oxygen, and so you have to be in the hospital to get the oxygen, or you're very weak and you're dehydrated because of COVID and just unable to eat and fever, extreme weakness. So maybe you need IV fluids and that sort of thing, things that you can't get at home. When your vital signs are unstable, so it would be, there's a range of blood pressure that's acceptable. There's a range of heart rate that's acceptable if you're not maintaining those. If you had a person was not mentating clearly, that would be another reason. So there's a whole host of sort of admission criteria that physician evaluates. And then sometimes, on any illness, anytime you come in with anything, COVID or anything, is this person likely to go home and get a little bit better, or are they likely to go home and get a little worse? And especially with COVID, what we already know is in elderly people and people with comorbidities, if you come in and you're already sort of on the borderline, you're probably not going to go home and immediately get better. You're probably going to need admission if you're not holding your own already by yourself. No oxygen, things like that. Does that help?
Yes, thank you. But also, my second question is, what are the criteria for discharging a patient once it's been in the hospital for a while?
Well, all the exact opposite. So if you had to be on oxygen in the hospital, you have to be able to be off of it. You have to be able to tolerate fluids and food by yourself without, an IV. People have to be able to move around. So you have to be able to get out of bed and walk in the halls. If you're too weak to walk, we need to work with physical therapy to get your strength up so that you can go home. So people have to meet discharge criteria as well to be able to go.
Okay, we have a couple of questions on the chat line, and then we're going to go back to Sue and then to Jeff.
Okay.
From the chat line, a simple one, I think. Number of us have oximeters at home, the same finger things that you get in the doctor's. Okay. Are those at all of use in this process?
I think
To take home readings.
Yeah, I think so. Because what you would want to do is if you see a change in your baseline, a change in your baseline. So let's say somebody has a little touch of COPD, but you're managing with your inhaler and your steroids, and you're fine. And your normal is you hang out maybe on 2 liters of oxygen, you hang out at 91, and that's fine. Your doctor's fine with that, or even 90 or 89. And then all of a sudden you're feeling yourself subjectively short of breath, and you take your oximeter and now you're at 86 or 87, and that's low for you and you don't feel well. And then when you go through the list, you're like, well, I actually do have a new little cough, and I'm feeling, I have loss of taste and loss of smell, and I'm very tired. Like, those would be good enough reasons to be evaluated. You could call your primary care physician and see to get in. More often than not, they'll send you to the hospital so that you can get testing.
Okay, Leah, does the same logic apply in terms of a baseline when we talk temperature? Sue was talking about the fact that most of us have lower than normal temperatures. I think I've been married 56 years, and I think my wife, whatever she's had as an illness, has never had a temperature of 100 or higher. Okay.
Yeah, we do consider that.
Okay, so if we're tracking our temperature and our oximeter, and they start going the wrong direction, those are indications that we should watch.
Yeah, and it doesn't have to be very much. It could be just a few little points, and sometimes people won't be very impressed with a tiny drop in someone's baseline. But I think in the world of COVID, especially if you have other symptoms, right? Because there's a group of symptoms and they're very vague. It could be from new cough, abnormal temperature, right? All of those. And so, especially if you have one or more, if you have one or more symptoms and a little drop in your oxygen level and a tiny bit of a bump in your temperature, I would consider that probably more than one symptom.
Okay. We've had a couple of questions about the drugs that are being used. I'm not going to pronounce it correctly, the
Remdesivir.
Okay, then the steroids, and that another one I can't pronounce. And then there's recently the plasma. Do you all use these, have experience with them? Any opinion on them?
Yeah, well, we are using Remdesivir.
Okay.
And we are having, I think that we believe we're having some decent success with it. It's an antiviral. So for your pharmacology, all of the drugs that end in the vir, those are antivirals. And so it's an antiviral that seems to be working pretty well. So we are using it. I am optimistic about all these other sorts of treatments out there. They all work a little bit different. So what steroids do is they interfere with the inflammatory response. And oftentimes when people get very sick, they have an overwhelming inflammatory response that wreaks havoc on humans, on our systems. And so the idea behind steroids is to block that overwhelming immune response and then interfere with it. Plasma is actually that is from people who previously had exposure to COVID and they have antibodies. And so basically they're giving, you're getting somebody else's antibodies against the virus. So I think that there's a lot of things out there that are pretty cool and innovative. And, I think there's a lot more to come on that.
But you're not using at this point plasma.
We have not used plasma here to my knowledge.
Okay. How about the steroids?
That I don't know for sure, but steroids are very common. And if I had to bet my money, I would say they probably do steroids along with the remdesivir.
Okay, we've got 4 people with questions. We'll go to Sue, then to Jeff, then to Lynn, then to Carolyn. Sue, you're on.
Well, I wanted to say that Lynn has had her hand up for a long time, so I was going to call your attention to that.
Okay. Lynn, I'm going to put you just behind Jeff. Jeff's on.
Okay, I have 2 questions. First is about testing. I understand that actually the best test is now considered to be a saliva test, which means you shouldn't need to have swabs or even a nurse to get the sample. All you need is for someone to spit into a cup or something. If that's the case, is the only thing that's stopping you from having more testing the actual processing of it by the lab?
So that's an interesting question because in this, because the coronavirus is so new and the testing has been new, a lot of it is around supply of the testing reagents and then the lab capabilities to run them. Even in our community, I know of at least 4 complete, separate, and distinct ways in testing that they're doing it. There's rapid testing, and there's not very many. We only get 20 rapid tests a day, so we only use it on our sickest patients where we really need to know what we're dealing with. Here at Memorial, we have something called a Panther test, where we get results in between 6 and 8 hours. And so if every patient who gets admitted to our hospital gets a Panther, our urgent cares, they're using a vendor and they're getting their test back in about 24 hours. And then when we're using commercial labs like Quest, it's a 3 to 5 day thing. At one point we were it was faster for us early on to send our own tests to our sister hospital in Oregon, and we would get them back sooner than using a commercial supplier. So as these new things are coming out, people are getting them, but there's high demand. And so the manufacturer actually controlling the supply of who gets what when based on like what your community need is. So right now, I'm not aware of anybody having saliva, but we know that saliva is rich with DNA and is very, for many other things, is a very effective way to test. It would be fabulous to have that.
And second, about masks. A lot of us have N95 masks left over from 2017, and I gather that they fail or they get stale or something after a certain amount of time. But I'm still using mine, first of all, because no one else would need it. I've already used it. But secondly, because somehow I feel that after 3 years, probably an N95 mask is still better than a piece of cotton in front of my face. Would you agree with that?
I absolutely agree. And here I'll tell you why. Because the N95, in order to work, it creates a good seal. And so particles can't get in. So the unfortunate thing, if our male colleagues that have facial hair, you can't get a good seal. But it's still going to cover your cough. And the main goal of all masking is to cover one's cough. The problem that comes up sometimes around some of these gaiters and these other things that are more thinner, if the material is like of a polyester blend that's very porous, and if you stretch it, you could probably see through it. If you cough or sneeze through that, there's a potential that some particles could, where the N95 may not be effective as protecting you if you can't get a good feel. And we actually do fit testing. We actually spray stuff to make sure people can't taste it or smell it when we have their N95. But even if you that level of a seal with your N95, having that on as a mask is way better than a single ply porous cloth mask.
Lee, we had a question on the chat that I want to just jump in here. Then Lynn, I'll finally get to you. And that was, if a regular mask doesn't protect you, it protects the other guy.
Yep.
Okay. How do you increase your protection? Is the answer the N95 mask?
The proper fit, the N95 will help you.
Okay.
And the shield. Excuse me. But you know, sometimes you see these bands with a full face shield. You've seen that. I've seen them even in the grocery store. And you know, we actually, when we go into patients' rooms, if we just have a plain surgical mask and then the big shield, we consider that to be pretty good. And we'll go into a COVID room with that. So eye shields are a big deal. If you want to protect yourself and the rest of the world, you have an N95 with a good fit. That's good. It can protect you a little bit, and it will definitely protect others if you cough. So if you have an N95, I don't have any problem with it.
Okay, Lynn, we finally got to you.
Oh, thank you.
Lynn.
Hi
Lynn is
there.
a patient.
Hi. So I have a comment and then a question. So my comment is I've been reading that there's evidence that people who are exposed to the virus while wearing a mask seem to get less of a dose of the virus and don't get as sick. They have a milder case of the virus. And so that's my comment.
You know what? Can I comment real quick on that?
Sure.
I think that it's probably not studied really well because it's hard to.
It's not.
But I think the thing is this, it sort of makes intuitive sense, because if you sneeze right in my face, I'm going to get the full force and breathe in all of the stuff that you sneeze on me. But if I have a mask on to protect you and you sneeze on me, some of it's going to end up on my mask and not even get to me. So the viral load has the potential to be less.
Correct.
So I think that even though it's not studying and it's probably not supported in the medical literature, it sort of makes some intuitive sense just in terms of blocking transmission.
There are some studies that are undergoing, but it's a lot of anecdotal information.
Yes.
People on cruise ships who didn't wear versus those who did, for example, and they all tested positive. And then my question, is Memorial Hospital participating in any research studies related to coronavirus?
We do some research here, but I'm not aware of any.
Okay.
But that doesn't mean that, you know, we don't have because some of it's like pharmacy, sometimes it's lab. You know, whenever we do human trials, we have permission, consent from, the participants. And I haven't been aware of us participating in that level, but that doesn't mean that behind the scenes, there's not some little trials going on.
Thank you.
Okay, Carolyn and then Marilyn.
Okay.
And then Randy.
Thank you so much. Oh, I lost her.
I'm here.
Oh, sorry. I want to thank you for your time. And also, would you make a comment on the CDC saying today that there would be a vaccine available by November 1st?
You know what? I haven't read that today because I was such crazy busy today. If that is true, I would be super happy about that, because I think everybody is a little worried about a combo flu COVID season. And, it is well known that influenza can be fatal as well. And I can't even imagine having patients have to combat both. So unfortunately, I haven't heard that today. I didn't have a chance to do any any reading, but
Mhm.
that's what they're saying. I think that is a reason for cautious happiness. And
Okay, Marilyn, and then Randy, and then we'll flip back up to Sue.
So today's New York Times, this just came out an hour ago, say that you mentioned the steroids and talking about 3 particular ones that have been found to be, they're strongly recommending. One of them is hydrocortisone, one is methylprednisone, and one is dexamethasone.
Dexamethasone. Yeah.
All right. So my question more is that as you read these things and you hear this as a patient, you come in, you're admitted, you know this information. How much say do you have, or do you communicate to the doctor to say, I'd like to be treated with these steroids? Who makes that decision?
Well, the thing is I have to say these docs are really good about keeping up on studies, and they also know that we, especially with the internet and how accessible information is, that patients are much more educated and much more knowledgeable about emerging therapies and emerging things than ever before. And so, I would always recommend having a conversation with a physician saying, I've read that steroids are helpful. Am I a candidate for this? And if yes, I'd like to know why what it's going to do for me. And if the answer is no, well, then why not? And so, there's different things. I mean, for example, what we know about steroids, this is like, I'm just being super hypothetical here. This has nothing to do with anything I've read per se, but when patients are on steroids, oftentimes we see their blood sugars go up. If we see people's blood sugars go up, and if you happen to be a diabetic, and we know that diabetics have a harder time with COVID, we might want to proceed cautiously if there's something else that we could use instead. So there might be some rationale behind there, but I think that, it's worthy of a conversation, and if there's some particular reason why they're going to opt to do something different.
So we as potential patients really need to keep up with information so we know what to ask for.
Yeah, absolutely. And and people ask a lot of questions. Like the questions that you all are answering or questioning to me, these are kind of questions that we field every day, all day long, from people who, have been reading, especially, in this time where COVID is scary. And so people want to know, and they want to be educated, and they want to be empowered to participate in their care and have a say-so in what happens to them. And so, it's beneficial to know what's kind of there so that you can discuss the risk and benefits of every treatment that's, a potential, and make really good informed decisions.
Thank you.
You're welcome.
Okay. We have Randy, and then there's a question I want to get from the chat line, and then Sue. Randy first.
My question is really sort of basic, but we were talking about masks before, and one thing I have wondered is, what's really the proper care, and what do I need to do with my mask? I wear it and I come in. Do I need to launder it every single time I come in from outside and have maybe half a dozen masks? When I bring it in, if I hang it up somewhere, because things don't live for as long, we know that on surfaces now, the virus doesn't last for 3-4 days. It's gone and dissipates. Is it safe to set it aside and then reuse it again the next day or a few hours later? I just wonder about what's the best cleanliness things with masks. I read somewhere not to hang them in your car on your review mirror, because then your air conditioning comes on and blows germs all over. So I thought that was informative. But I'm just wondering about what's just really general hygiene for a mask and proper use and care.
What we do here is we will reuse our masks throughout the day, and if it's not soiled, we'll use it beyond that. And so we actually just put ours in a little paper bag. See, I've got one right here, and we'll keep them. And when they're soiled, we toss them. However, with the caveat being is if we're in a room with a patient with COVID, then the mask it's a switch out. I don't intersect with patients all day long because I'm in an administrative role. So with that, if you came home and you put it in a bag or you had it somewhere and you didn't have anybody, you weren't in close contact with anybody who coughed on you, then it's probably fine. Because what you want to protect against is, here you've got your mask on. So if you're coughing, the inside is your germs. But on the outside, if somebody coughs on you or gets in close contact with your mask, the mask is contaminated, you would want it to be laundered. And let's just say you're out there and you're out walking your dog and somebody else is coming towards you, also walking their dog, and you each step to the opposite side of the sidewalk and you just walk past each other. That I would probably not call that worthy of laundering your mask as soon as you get home. But if you're out shopping and you're trying to stay away from people, but you kind of find that every time you turn around, someone's there, that might be a reason to come home and go, you know what, I'm just going to wash this thing.
Okay. Leah, one of the questions that has come on the chat room, a number of us have pre-existing conditions that would be of concern if we were to come down with the COVID. Okay. In terms of when we should be saying we need to see a doctor, we need to see the emergency room. Okay. Does that change the criteria from what you talked about earlier?
Yeah. No, it does not. Just, happen is if you are getting those symptoms and you're feeling sick, then if you have comorbidities, and it's just more of a reason to not delay, but you should still be coming in if you're feeling ill.
Okay. Sue, you had a question.
Yes, with the idea that the vaccine's going to be ready November 1st, do you really all believe that? I mean, that it
No,
would be safe,
that's why I asked.
have been thoroughly tested, and, or is this a ploy by Washington to sort of ease our minds?
Well, so that's a great question. And what I would say is that I would want to read the right? Because the thing is that if it's not been tested on human subjects, then I would probably opt not to take it. I really want to be the first one.
Yeah.
But if it's gone through some human trials, and I have read that there's some stuff that's out there promising. And so then you want to look for any bias in the actual article. And what that means is like, who's paying who to develop it? That kind of thing. Is there any reason, to suspect that it's not just based on pure good research? And then things like this, right? Expert consensus. I think, your primary care doc, what he or she says, like a lot of physicians are very skeptical about, just by nature, about vaccines. And so, if they feel like it's going to do more harm for their patient, they're going to hold off on recommending it. Because what we don't want is like the cure to be worse than a disease that's already pretty bad.
Leah, I think we're about at the end. I'm going to ask the last question. I get the only one that deals with the newspaper article.
Here we go.
If you have been in the hospital in August, in the emergency room or in some other condition that had you in the hospital, and you haven't had reason to do so otherwise, should you get a test for COVID now? Just for the fact that you've been in the hospital.
So here's my disclaimer. This is not an official statement by the hospital, but if you're asymptomatic, I would say no. So in the emergency department, right, if you've only been in the ED, we have had 0 conversion in the ED from patient to patient, nurse to type patient, or doctor to patient, or staff member to staff member. We've had not one case, and the ED has had more than more COVID patients than all the other patients in the hospital combined. So what from the newspaper, this little situation is confined to one small area. Our infection prevention specialists are doing a lot of contact tracing. And so if they are looking at their contact tracing, if they believe that patients are at risk, at some point they're going to be reaching out. If you're ill, you should come to the hospital. If you have symptoms, you should come to the hospital. And what I would say is that from the inside, it is very small and very contained. And there's immediate containment going on.
Lee, thank you so much for joining us. And that was very informative. Yes, we all,
Thank you.
and we appreciate the time. And
Thank
to
you so
everybody
much.
else, we are not having a meeting next week. Our next meeting will be the first Wednesday in October. That's for the futures. For the symposium, we have our first meeting a week from Sunday, and it will be a nationally recognized woman speaking on the passage of the suffrage amendment. I hope you all join.
George, correction. George, you said futures October. We're meeting in September?
We're not.
We're not.
No.
Okay.
Next meeting will be the first Wednesday in October.
Okay. So disregard your Oakmont news that'll come out and say it's
Disregard the
September.
Oakmont news. Okay, thank you all, and thank you again, Leah.
All right,
When
thank
is the
you.
meeting on suffrage again?
The 13th, September 13th.
But it will be up. Let
Yeah.
me unmute.
That information will be in the Oakmont News, and it will be available on the website, and we will email you if you're in the symposium email.
Okay.
Okay,
Yeah, and her talk will be up from Thursday after night on.
okay. Bye all.